Will you be induced if your baby is measuring big, or is induction even necessary for large babies? Hi, I'm Fray, and I'm a semi-retired senior midwife and a best-selling maternity author, and we're going to go through this today because there are huge discrepancies around the world as to how this is managed, when there are some very straightforward guidelines on it as to what is best practice. But certainly in the USA especially, I am constantly, almost on a daily basis, hearing about women who have been told their baby is big or large or macrosomic, and that they need to be induced. And that, as a protocol, went out the window some time ago. So let's go over it. I want to empower you with the information that's current, so that you can make informed decisions. So your consent is informed. All right. So if we look back to, say, around 2016, there was a general kind of acceptance around the world that induction of labour over 38 weeks, if you've got a suspected fetal macrosomia, which means a suspected large for dates baby or large for gestation dates baby, is associated with a significant decrease in fetal fractures and therefore can be considered a reasonable option. However, it came with caveats, and that is that there are a lot of uncertainties around the diagnosis for gestational age, and that women should be informed of that fact, meaning that the third trimester ultrasound scans have a sensitivity accuracy of only around 60% of macrosomia. So that means 40% of the time when they are estimating the fetal weight to be large for dates, it's not. And so women are supposed to be getting told that. That was back in 2016. Now, also over recent years, some really, there's been a lot of study on this topic, a lot. Okay. So the National Library of Medicine highlights that a whole lot of research was done around obstetric attitudes towards inductions. And what they found was that 57% of the time, or thereabouts, one or more of the following factors were determining the obstetrician's decisions on whether they were or weren't recommending an induction for a suspected large for dates baby. And they were: the doctor's relaxed personal attitude towards inductions. You know, willy-nilly, everyone's getting induced. Normalization of that deviance, meaning that the decision is based on the culture, that's a common thing they do, and not based on evidence of best practice. Number 3, freedom of doctors to practice as they see best, meaning that there's no professional accountability when deviating from the gold standards of best practice. No one's going to rake them over the coals and go, why did you induce that woman? It doesn't happen. There's not a reflection like that. Number 4, limited attention placed on the risks of the inductions. I'll stop saying numbers. Next, lack of understanding regarding the risks of inductions. Next, being unaware of the short and long-term neonatal consequences of such interventions. Next, desire to expedite the birth process and have more control. Next, creation of a production system to ensure that women deliver like clockwork, preferably during daylight hours. Next, lack of knowledge and lack of comfort with natural birth. Next, not trusting the natural and normal birth process. Next, fear of natural childbirth. Next, financial reimbursement incentives, meaning they earn more money if they have to intervene, can claim more from insurance companies. Next, personal convenience. And the last two, planned absence, meaning the doctor's planning on going on holiday, so that's why he's inducing you, and fear of litigation. So if a doctor says we should be inducing you, nobody's really turning around going, why? But if they didn't induce you, there's that fear that later on somebody goes, why didn't you induce her? So that fear of litigation. So that is horrific. That's almost 60% of the time, one or more of those factors is part of the decision. That's more than half. That's the majority of the decision is not being based on best practice gold standards. And this is what I see in the States especially. Europe, UK, New Zealand, Holland, yeah, way better. This sort of stuff just does not occur in the same volume anywhere near it. Okay, so, but in 2021, the NICE guidelines came up with their current best practice guidelines. NICE is the National Institute for Health and Care Excellence, and they really are regarded as the gold standards globally from a maternity healthcare perspective, and from other than just maternity, but particularly maternity guidelines. The NICE guidelines are the gold standard everybody should be following, and most countries do. Okay, so they did a risk versus benefits on basically doing inductions for macrosomic or suspected large for date babies versus the expectant management system, they call it, which is basically waiting for spontaneous labor. There was no reduction in the amounts of C-sections required. There was no reduction in the amount of perinatal deaths. There was a slightly higher level of shoulder dystocia, 4.1%, 6.8% instead of 4.1%, but no decrease in brachial plexus injuries. And that tends to be the main issue and concern around shoulder dystocia, when the shoulders get stuck, as the brachial nerve getting damaged and a baby ending up with Erb's palsy. So we had a few more tighter deliveries, but no negative outcomes from that. But there was also 4 times higher rates in inductions of 3rd degree and 4th degree perineal tears. Instead of 0.7% with natural labours, it went up to 2.6% with induced labours. Now, the committee noted that was an unexpected result, because the whole point of inducing is to, in theory, being giving birth to a smaller baby. So why the heck are women's perineums tearing more with supposedly smaller babies? And the answer is simple. It's because the induction process involves so many interventions. They end up with like oxytocin drips. They end up with epidurals, which means they end up with more higher levels of forceps and ventouse deliveries, which is why they end up with higher levels of perinatal tears. I mean, the whole thing is just, it's 1 + 1 = 2. It's not rocket science. So this is the gold standard recommendation currently put out in 2021, the NICE guidelines. This is the wording. Suspected large for gestational age babies suspected of macrosomia are at an increased risk of having difficult births. Preventing babies from getting too large by having an earlier birth may mitigate the associated risks. However, the available evidence is not sufficient to recommend inducing labour and having an early birth over managing the pregnancy expectantly and waiting until birth starts spontaneously. That's it. That's the conclusion. So feel free to look up NICE guidelines on macrosomia and print that out for yourself. Benefits versus harm is the little title. Print it out to your obstetrician, present it to them and say, why are you wanting to induce me? Bye, everybody.